Okay.
Hi everyone. Hi, good afternoon from Hong Kong. I know people from UK, Hong Kong, and also Indonesia have joined. I'm not sure if there are people from Singapore. Our different MOUs have joined. So welcome everyone. And this is a webinar jointly organized by the RTPI and the Hong Kong IP. The title is Healthy Cities and Communities, Learning Planning Practice in the UK and Hong Kong. I'm Rebecca, Vice President of the Hong Kong IP and the convener of the Hong Kong IP External Affairs Committee. Philip, sitting next to me, right hand side, from RTPI, and I will be the moderators today. A very warm welcome to all of you. We are delighted to have three guest speakers with us today: Mr. Michael Chan, Dr. Fan Ling next to me, and Ms. Marisa Chisholm to share with us how public health is integrated into planning, policy, and practice. And Dr. Fan and Philip joining in person at the Hong Kong IP office, Michael and Marisa joining online from the UK. We understand that there are now about how many 100 people joining, and so hopefully more people will be joining us soon. So we'll start with Michael's presentation, and then Dr. Fan and Marisa, and followed by a Q&A section. So before we start, here are some housekeeping points to help you get the most of the section. The webinar will last for about 75 minutes and will be recorded. After this section, you'll receive a link to rewatch this webinar and to be asked to complete a survey. We will answer your questions in the Q&A section after the presentations. Please post your questions in the Q&A box at any time throughout the presentations. You can find it on the right-hand side of the screen, where you can also vote on questions. We'll collect all questions and we'll do our best to get to as many as possible. If you like closed captions, press the CC button at the top of your screen and then you can choose your CC language. All attendees are muted by the organizer. If you lose connection to the section, then please refresh your browser and try rejoining via your link. Now I would like to hand over to Philip to say a few words. Philip, please.
Thank you, Rebecca, and also a very warm welcome from myself and the Royal Town Planning Institute. My name is Philip Czafol-Zelenko, and I'm a committee member of the Royal Town Planning Institute in Yorkshire, and I'm also a member of our international group there. For today's events, we are joined by planning and health experts from the UK and Hong Kong, and I'm pleased to introduce briefly our first speaker, who is Michael Chan. Michael is a chartered fellow town planner and has 15 years of policy, research, and public health expertise. In his research, Michael focuses on system approaches to local planning for health and health in statutory local plans in England. Michael helps implement research and evidence into actionable guidance for governments, practitioners, and international bodies. Michael leads healthy planning at NHS Property Services and is currently undertaking a PhD at the University of Bristol. I now hand over to you, Mike. Thank you.
Thank you, and good morning to those from the UK, and good afternoon, good evening to those in Asia. I would like to give you a presentation on a very strategic perspective on healthy planning in the UK. So that's my presentation today. I would like to begin really with a really interesting quote for you. So the inevitable strain of life can be eased by good housing conditions, good working conditions, good opportunity for the enjoyment of leisure, freedom for proper rest, with a proper opportunity for fresh food. And actually, that is a quote from a Health and Garden Cities pamphlet from 1930s here in England. But that particular quote is very interesting because we can also associate that with any modern day planning policy around healthy places. So we haven't actually recognized and moved very far from our understanding of healthy places from the 1930s or from history. So which is great that we are still talking about it today. The evidence around planning for health has actually been strengthening over the years. We know from the evidence from both academia and the different sectors that the link between the environment and health is very strong. So from the top left column hand there, we have the Farrell Review from a very prominent architect, Sir Terry Farrell, looking at the link between the built environment and health. And he recognized in his review from 2014 the link between planning, housing, and health. Going to the right, the Parliamentary Committee have recognized the link between planning and environment and health. Bottom left, the public health system have recognized the link between the built environment and health and the role of spatial planning in the agenda. And then from the bottom right, we have academics from Keller College and Oxford University, again, looking at the evidence around this particular agenda. So all in all, we have a very strong understanding and the evidence around planning for health. And the key question is, are we taking action to deliver those key issues? A few key things to note in terms of the health threats and challenges, at least what we face here in the UK and in England. And actually, the Chief Medical Officer for England reports on these health trends annually. They present quite useful evidence or surveillance about the health of the nation to the government, and they can give recommendations to governments about what actions we can take across the health system or wider systems around planning, housing, transport, for example, to deliver those issues. So the past few years, the CMO for England have produced reports looking at obesity in 2019, in 2021, looking at coastal communities, health in those communities, in 2022, air pollution, in 2023, aging society, and 2 years ago, cities and health, within which there's a chapter on housing and a chapter on active transportation. In all of these annual reports by the medical officers in England, there's always recommendations around the built environments that we can take action on as town planners to improve population health. A really key thing to bear in mind in terms of looking at the health is the geography of health inequalities and geography of health. And obviously in today's webinar, health that we face here in the UK will be very different to health faced by those in Hong Kong, Indonesia, Singapore, Taiwan, Korea. So we have to be very mindful that health varies by geography and also over time at that global level, but also quite localized level as well. Here in the UK, the majority of England areas and across the nations in Scotland and Wales, for example, have seen declines in healthy life expectancy below the state pension age of 66 years from recent evidence base. You can see from the map there that in England, in some cities, we've mapped out life expectancy along railway stations. You can clearly see in Birmingham, the left diagram, those living at the north of the city living 82 years if you're male, but if you're living in the south, then it's 76 years. So again, it's quite a difference just along the railway line. In all of these statistics, actually deprivation is a key common denominator of health status. So if we tackle deprivation, we can help to tackle some of these health challenges. So what can the planning system do about it? So the action for the planning system is this narrative. So we understand place, health inequalities, and the likelihood of developing diseases are very much linked. As I mentioned before, the evidence is very, very strong. Because the numerous costs of unhealthy places fall so heavily on the health service, whichever health system you operate within, it is essential that we have the right system, right people, and the right funding in place to maintain the long-term focus on prevention and protecting population health. And planning for health doesn't happen by default. So good planning will not happen by default, and bad planning will not happen by default. It's always happening because of a regulatory system that we have to make sure can be supportive of the health agenda there. And the benefits can be seen across the different society, environments, and economy. So if you tackle environments around green space provision, healthy food options, good air quality, active spaces, healthy homes, you can achieve a range of priorities across government sectors and the society. So you can achieve advancing health equity, for example. You can achieve reducing demand on the health and care system. You can secure children's health. You can improve productivity of the population. So by doing good planning for health, you can achieve multiple priorities. So you're not doing it in contrast, in conflict with other priority areas. The RTPI has published guidance reports in this area, I think about 4 or 5 years ago. And this report called Enabling Healthy Placemaking outlines 7 steps for planning for healthy environments. Firstly, moving this debate forward, so we know the evidence, so what do we do next? Making collaboration work, how can we work across sectors, private sector, public sector, NGOs to make planning healthy places a reality? How can we formalize health principles in the planning process? And they name-checked health impact assessments in this report. How do we equip the planners with the right skills to take action, working within the planning system that you have? How do we resource planning, the system, and the profession adequately? How do we engage the public in the conversations around planning healthy places? In most situations, the public can give us feedback about what makes them healthy and how they would like to reflect those aspirations in urban development. And then finally, shaping the future. How can we be also planning for the future, 15, 20 years ahead, but also be resilient to the challenges that we may face in the coming years? So I'll really encourage you to refer to this RTPI research paper on enabling healthy placemaking. Just to give you a few spotlights around what's happening, at least in the English UK, around planning for health. So one of the research that was done here in England was looking at the local plans, which is the statutory documents that all local planning authorities in England have to produce within the time frame. And the research here looked at a number of determinants of health, looking at air pollution, green space provision, active transportation, food growing, and issues like that. And the key idea was to look at whether they reflect health in those policy areas or whether those policy areas exist at all. So without looking at too much the detail of the colors, the darker the color means that the local plan has a policy in place and that the policy references and refers to health considerations. The lighter the color, whether it's yellow or green, means there's either no policy or that the policy exists without any reference to health. So actually, the planning system, at least in English, local plans, air pollution, noise pollution, green space provision, those areas are quite strong traditional planning topic areas, and therefore we understand the health implications of those policy areas very, very well. However, for the other determinants, for example, the bottom 2 right maps around urban heat island effects, overheating, and some other uses, actually we're very poor in English local authorities in thinking about those issues, mainly because of the fact that there's no training around those areas, or actually national policies don't articulate those areas strongly enough around health. That's why we're seeing so much disparity and so much inconsistency on the coverage of health in those local plans. If the ideal position is that the maps you can see on the screen should be all blue, but obviously that's not the case. So we do have a way to go to work with those local authorities to make the colors blue and they reflect the health determinants in their local plans. So as I mentioned, the RTPI's Healthy Placemaking report does mention the use of health impact assessments. And health impact assessment is something that we promote a lot in England. Planning guidance does suggest that an HIA is a useful tool to use where there are expected to be significant impact. And therefore, we are expecting planners and those working in the planning system to embrace the use of HIAs. An HIA helps to identify the health and well-being impacts of a plan or a planning development and then make recommendations for those improvements. From current research, about 29% of councils have a clear local plan policy to require HIAs. There's not 100% coverage, but that's a good, nearly 1/3 of councils here in England. 19 of those local plans were subject to an HIA themselves, so they were assessed by an HIA to help improve that plan. Obviously, our idea is to make that 100%, but for now it's about 19%. The key lesson from England around the use of HIAs, and I hope you can embrace the use of HIAs in your context as well, is that actually HIA support is variable across England. We don't have a centralized policy across the UK on HIAs. Each of the UK nations have their own policies. So for England, our support is looking at how we build HIAs into the project, whereas Wales, through their HIA support units, they're focusing on embedding HIS into the policy plan-making process. And likewise, in Scotland, they have a support unit there, building capacity around HIS across the whole system, not just planning, but including planning as well. The other spotlight is looking at the health and design practices. In England, we are required to prepare design guides and design codes and help shape decisions that create places that are safe, inclusive, accessible, and which promotes health and well-being. That's what national policy requires us to do. Local design codes, which has been around for a number of years, but has only been made a legal requirement here in England, are important because they provide a framework for creating healthy, safe, and distinctive places. And current guidance around that looks at health and well-being in homes and places as well. The key question I pose to you, again in your context, is how can existing local health priorities and those related policy objectives around health be embedded in the design coding process or the general design process? And how can health stakeholders in the health system or in public health be involved in those design coding processes? Because in general, the health system do not recognize or understand the design process. How do we engage them in the whole process? That's a key challenge for us to tackle going forward. And then in the kind of final spotlight is looking at how we can secure infrastructure. So yes, we can promote healthy places, healthy placemaking through the environmental improvements. But in many cases, we do need contributions towards health facilities, because if you're sick, you need access to a health facility, right? So there's a need in policy for planners to take a consistent approach to planning and delivery of health infrastructure, including hospitals, but also neighborhood health centers as well. In England, we secure around £7-8 billion per year from developers from development, and it's estimated that around 148 million remains unspent across the country for health and care infrastructure. So we can leverage some of that money to spend on additional improving infrastructure around health that can go in some way to improving population health. So finally, in that kind of red box there, having a strong planning policy is essential around health infrastructure securing, because then we can make sure that development aligns with what community needs around the healthcare and treatment opportunities. Now, how are we seen by the health profession? Many of you who are working in planning may say, well, why are we doing planning and health? And those in the health professions will be thinking, why are planners doing health and planning? And actually, the WHO, the World Health Organization, recognizes urban planning, urban planners as an occupation allied to health, because of the fact that our contributions and our actions affect population health either directly or indirectly, and therefore they do see urban planning as a very important lever and workforce in the public health system. And likewise, here in the UK, the Royal Society for Public Health does recognize town and country planners as an allied workforce because of a vital role in improving or even reducing population health. And therefore, we have to recognize that we are very much seen to be part of the health system and very important part of the health profession as well. So to end my presentation, a kind of few key messages to put across to you. As I said earlier, we recognize in evidence, place is a very powerful determinant of health. Where you live and how you live is very important, and planning is an essential mechanism for delivering in healthy places. Health does vary by geography. That means we have to plan very specifically for that location rather than having too generalized interventions that doesn't work for that community or that place. Healthy planning is a long-term investment. So we need to make sure that we invest in healthy planning policies now, not tomorrow, but now, in order for us to recognize and realize the kind of benefits in the longer term. And hopefully that reduces demand on the healthcare system in the future. Planning healthy places depends heavily on the right people and the right skills and right partnerships. And I would hope that Royal Institutes for any of the built environment professions here in the UK are investing in CPD training and learning and development, so therefore we can build up capacity within our profession. And then finally, healthy outcomes do not happen by default. They must be designed and secured and regulated, because as I said earlier, planning for health is not something that happens by default. One final quote there to leave you with my webinar. Obesity, inactivity, depression, and loss of community has not happened to us. We have legislated for it, we have subsidized it, and we have planned it in the past. So if we were the problem and we are the problem to those health issues, if we choose, we can legislate and subsidize and plan for health promotion and ensure that the planning system is a positive tool for change rather than a negative barrier to health promotion. Thank you.
Thank you, Michael. Thank you so much for a very thought-provoking presentation. Your last point, healthy outcomes do not happen by accident. They must be designed, secure, and regulated. I think that's a big reminder to us as town planners that when we design our cities, we should be very mindful of what you just said. Thank you for that. Now it's our pleasure to introduce our second speaker, Dr. Fang Ling. Dr. Fang is a surgeon as well as a social innovator. He's the founder of Health in Action. He's also the chairman of Forget Thee Not, an organization providing end-of-life planning services to help people live their final moments with greatest dignity. He's also the director of the Happy Aging Laboratory Foundation as well. So I have more about him, but I don't want to spend any more time. Let's welcome Dr. Fang to share with us.
Thank you, everyone. Good morning and also good evening. Thanks, Michael, for setting the tone. Very good. I save a lot of time not to talk about why I'm here, because I'm really fans of how to use the space to make people healthy. And maybe a lot of you recognize Sir Michael Marmot, renal public health expert, who is doing a lot of great work, not only in UK but around the world, because he developed the concept how to manage the social determinants of health. And I'm also a big fan of him. And indeed, when he visited Hong Kong for the last few times, he came to our organization, Health in Action, because we are really putting the health inequity or health equity project into the ground. So, okay. So to keep it short is I think Health in Action, the name in short is HIA. Although we are not health in impact assessment, but indeed HIA really is a very good name. For the health, we talk about the right to health, because it's also related to how we use the space and also how to empower and enable the people to make limited space to get the healthy food, how to access to essential health service. Is it only rely on the public service? I think there could be more innovative way to do that. And that's why we try to engage even the layman or even the underprivileged on how to make the living space to be healthy. Yes. Yeah. So just to give you a snapshot, our organization is based in one of the Hong Kong poorest area, which is Kwai Tsing. This is one of the areas should be the bottom 4 poorest district. To give you a snapshot we don't have doctor. I'm just a volunteer, but we have a team of transdisciplinary profession, from nurse to pharmacist to different kind of allied health. And most important is we engage our underprivileged people in this area, because they are quite condensed in this area. And a snapshot of our service is in 2024. In 1 year, we have engaged such a big number of the population locally. So what actually we are trying to do, this is our concept, we are not providing service only, but we are trying to build a community healthy access base. That means that, yes, there's a lot of the public service set by the government, but even for the underprivileged, they really do not know how to navigate through the different systems, the health system, the social system, or even where to find healthy food. So we engage to build a different key stakeholder, like the restaurant, workplace. We go to different schools. We go to a special area called, for example, estate-based or region-based. We build a healthy neighborhood. And we engage Muslim, we engage Buddhist, we engage Catholic and also Christian church in order to promote health through the space. And of course, a small shop. So although we only have healthy living lab and also we set a community pharmacy, but we go out of our center and try to engage individual, because I think individual in a group or as a key carer of the family, what they can provide is they are not only a receiver, they also have their social capital, they know the resources, and they form informal group, which is, I think, is very important in order to penetrate into the different space and also to engage some of the key personnel. So I would try to, set up. Yeah.
Yes.
Full.
Yeah.
So I would try to give an example is how we engage one healthy neighborhood, or what we build a healthy neighborhood in order to build a community stakeholder which is rich to provide different kind of the service or the kind of the engagement that the general individual want to have. So I take an example of Gong Fai Wan, which have a lot of people living in a subdivided units or in a remote way, I would say. As Michael have been mentioned, in UK, one important thing is even in Hong Kong, a lot of people, no matter they are elder or they are relatively young, in the middle age, they are lonely, they are disconnected. So I think this is also one key things why the people cannot navigate through the system, because they are quite siloed. So how we do? First is we use several principles. First, we go to the place. That means we are outreaching. And one time is no use. We are regularly being present. And we use different kind of engagement. We use existing member, we use health as a topic to engage the people, because a lot of people have pain, a lot of people do not know how to manage their diabetics, a lot of people lack of the time to sleep and they want to get a good quality of sleep. Taking pills, I think, is not the solution. So the placemaking to engage the people is what matters to you. Of course, we are not talking about we can give you the money or things like that. We are talking about how to improve your health. So I think this is quite important to arouse the people to come together. And so we get what matters to them. For example, for the subdivided units resident, the living space create a lot of, for example, mice. The indoor air quality is not good. When they open the door, it's a very hectic traffic that, okay, they will close the door. And they don't have too much resources, so they have to endure the time that is not a bad place for sleep. The air condition is not really that well. They have faced the hazard of fire, and they don't have a proper space to even have to take a meal and how to cook. So all of this sewage system, drainage system, they need to wash and also have to go to the toilet at the same time in a very congested area. But we can still improve that using innovation. And of course, we take out a lot of the different kind of the chronic disease they are engaging, and also what they need is, for example, dental care. And based on this kind of the analysis, I think how to get them to know to understand that indeed we are the one close to them and also can to help them. And based on this, we try to turn them into service receiver, then slowly to supporter. That means to support our service, to try to promote our service. And then slowly through changing their own life, they can influence the neighborhood. And then we try to train them, and then they can promote our project to other people and to create the kind of the network. And finally, they create the project for themselves in the community. So that suddenly we have more than double, triple people to help us to go through this engagement. And so we try to see is how to turn from their concern, disease-based, then change the lifestyle. And then even for some of the kind of the small symptom, we try to let them know that they can get more help. And then through that, then slowly they become active participants. And then one thing they want to do is, where can we get the healthy food? So we try to build a network called Healthy Restaurant. How we do that? First, we concern about the staff health. We provide free health check for them, and then to have a health analysis, provide them the healthcare plan, and then slowly we help to review the menu, change a little bit, this and that, bit by bit, so that later on, how about doing the vaccination, flu jab? Slowly we build up this kind of the network, and then they give us as a space to engage more people to get into the health service. And this is some of the example just to show you. And finally is what is the step forward? I do think that the people can love their community, but how to love the other people? So how about doing a kind of the community festival all by themselves? And indeed, this is how we do that, is try to make them to concern about the public health around the district and to spread the message. And this was done just in the last Christmas. This year earlier is the Chinese Lunar New Year.
Japanese.
Is there any evidence? Because finally, if we want to convince the government, we have to let them know this kind of the community origin, try to make the public space more healthy, can have evidence. This was done by the Chinese University of Hong Kong Social Science and Social Work, which has not been published because this is only an interim report. But it already showed that through this kind of promoting ownership, promoting self-advocacy, and allow the people to innovate for themselves through the support of a kind of the health team like Health in Action, they could change improve their mental health, their subjective health status, but most important is they find the meaning of life and the happiness. I think this is one thing every government would like to see. So I still think there's a little bit of time, because I think very important is why I'm here is I've been working with the Hong Kong IP for over the last 2 years, is how to put the concept that I've been doing in Gong Fei Wai into, for example, could we do some renovation for very old district, for example, Yau Ma Tei and Mong Kok, which is quite famous for most of the people, even overseas. This is a highly congested area. Same, we engage the people. We engage the local NGO, especially those focused on the underprivileged, to get them involved. And then we do the survey and we find what is the concern of the community. For example, they don't have the space to do exercise, and they have majority of them don't have the time even to walk more than 10,000 steps per day. And about the community environment, they are not quite satisfied. Even they don't want to go to the street because the comfort level is very low. The walkability is really not satisfied. So we, based on that, we get this kind of the information. Then we try to engage more stakeholders, including different government departments, to persuade them, could there be a way out? Maybe we can provide you the solution. For example, if the idea, oh, that is a reminder, very quick. If the idea is come from the public, usually this is more easy to talk to the government. If we talk about health, it's also a very good platform that we can go through some of the barricade. So finally, I don't go into detail because this is very easy to understand as a city planner, and also people with public health is how to make the street more walkable and can create a kind of more connection, less loneliness, and of course, we'll see the public health status to be improved in the long term. So I will stop here and to get more discussion later on. Thank you.
Thank you. Thank you.
Thank you very much, Dr. Pham. That was very insightful. Thank you for sharing your presentation with us and those two examples from Hong Kong. Just want to now introduce our third speaker of today's webinar, who is Marissa Chisholm. Marissa is a policy planner at Aberdeenshire Council in Scotland, where she focuses on the integration of health and well-being into planning policy. As part of this, Marissa has collated evidence about the food environment, including school zone analysis and community engagement, to inform approaches such as takeaway management zones, and works closely with public health colleagues to explore how these approaches can be translated into policy and delivery in practice. I'd like now to hand over to Marissa, our last speaker. Thank you. Over to you.
All right. Good morning. Well, actually, instead of saying good morning or good evening, I'll just say good time zones to our very international group. As stated, my name is Marissa Chisholm, and I'm a local development policy planner located in Northeast Scotland. And of course, today I will be discussing the shift in public Scottish planning, moving us from viewing health previously as something that is very avoid what's destructive to a community, that approach to embedding it into the very heart of our system. And as we've seen, public health is a very massive topic. If we tried to cover everything that Public Health Scotland, the NHS, and our 32 authorities have done since the implementation of our new policy in 2023, we'd be here till next month, maybe even next year. So I'm going to, like the others, narrow the lens and focus on projects and areas where I do believe that the most health bang for our buck lies, which is within the food system and the built environment. And I do want to show you how we can move our health statistics from into actual defensible policy. So moving on, for my colleagues that are out with the Scottish border, let me introduce NPF4, which is National Planning Framework 4. It was adopted in February of 2023 and has had a bit of a whirlwind revolution for us. NPF4 explicitly moves the planning system away from just delivering generic growth for growth's sake. We actually now have a statutory mandate that requires managing land use for the long-term public interest. And the framework does specifically define that as improving health, well-being, and reducing inequalities. So as professionals, we do know that these high-level frameworks often do lack a little bit of bite when it comes to development. So how is this going to be enforced on the ground? The teeth of that do lie in policies 23 and a little bit of policy 27 of NPF4. Those are the definitive legal markers. Development proposals likely to have adverse effects on health will not be supported, full stop. And it does shift the burden of proof onto developers. So in other words, for major and national developments, a comprehensive health impact assessment will likely be needed. And this is a very intense departure for us. And it is causing a huge feeling of intensity and excitement in this specific 10-year window. And why is that? Well, currently, every single local development authority in Scotland is in the process of drafting a new local development plan, which of course is a statutory document, to align with NPF4. And as folks in the planning world, you do know that an LDP does lock in planning policy for a full decade, meaning that once these are implemented, if a planner wants to reject a problematic proposal based on health data, the legal framework to do so must be baked into those LDPs. Otherwise, they have no ground really to stand on during appeals. So this is a very, very exciting, but very, very nerve-wracking once-in-a-decade window for those that are very interested in public health. So how are we going to make sure that public health isn't pushed aside in the drafting process? Well, on top of NHS boards that are now being specified as key agencies, we are legally obligated to sit at the same table and integrate our data with NHS and other key agencies that are involved in public health from day one. Looking at the different stages of the plan from the high level, it does look like this. So if we're starting on the very left hand of the side, looking at the food environment as an example in Scotland, we do have an evidence report and then something called a gate check process where a reporter reviews our evidence before we can even start writing the proposed plan. So an example of this process within Scotland itself is Midlothian Council. In September of 2024, they worked hand in hand with their local NHS, which is NHS Lothian, to create a supplementary evidence statement. They presented this with their evidence report and demonstrated that the high reported rates of obesity do have a spatial link to the density of hot food takeaways in their area. And because that spatial link was supported with evidence, their evidence was approved and they were able to implement policies based off of that for their prepared plan that is going to be moving forward later on. And eventually, after the adoption of this plan or any local development plan, when planners eventually refuse something like a takeaway application, they legally will have an approved evidence base standing behind them. And this is just an example of evidence and approaches to mitigate what we like to call, in big terms, an obesogenic environment within Scotland. Moving on, again, we can never have enough evidence with this, especially when it comes to, for example, councils like Aberdeenshire, which are very large in area and have various different types of settlements. We can't really just draw a circle on a map, say too many takeaways. That's just not viable. So we are looking at other ways to obtain very hyper-local granular data that does prove, or at least support heavily, that the community is suffering in health or in their food environment or their food choice because of the physical layout and the built environment. So one of the solutions to this is through something called the Place Standard tool, which was developed by Public Health Scotland. It has actually gained global endorsement over the years from the World Health Organization specifically. And as discussed previously by our previous speakers, engagement is notoriously difficult to quantify. So this Place Standard tool uses a visual compass diagram to divide a subject into 14 distinct themes to capture the holistic view of a space. So communities are guided through structured conversations and they're asked to rank things on a scale of 1 to 7. And currently we and other agencies throughout Scotland are operating a pilot of the Place Standard tool for the food environment, which it does sound great. But I will be a devil's advocate before you guys can be devil's advocate and do say that it is very difficult to translate qualitative data and engagement data into defensible policy, which is fair. But the genius of this tool is that it bridges the gap of the lived experience of a community to that rigid professional reality through capturing those 1 to 7 scores. That's your statistical baseline, but you're also able to take in the consideration of that qualitative data. And so this tool does allow us to identify precise physical barriers to things that are determinants of health, specifically right now with public healthy eating, which also does merit and have a benefit of shifting the problem of healthy eating choice from individualism and your individual choice to identifying issues and infrastructure that we can change with our planning. At the same time, on the right hand of the side, we have health impact assessments that are getting a lot more attention and guidance. Our neighboring council, Aberdeen City in particular, has published new guidance on when and how to implement a health impact assessment on a site scale. And again, it is shifting the burden of proof onto developers to prove how their design supports population health. It does force health first mindsets during the design phase and not as an afterthought. So moving on, more on the food environment, of course, as it is my primary focus at the moment, particularly around childhood obesity and other social determinants of health related to deprivation. We have started using individual level GPA data to map exactly how much exposure children have to unhealthy commodity advertising and takeaways. And this is why we have seen an emergence of, pardon the pun, an appetite for takeaway management zones similar to those that are already implemented in England that are basically a 400-meter catchment around schools. And as planners, we are accepting that the diversity of our high streets are a health intervention. So for example, if a child's environment is saturated with hot food takeaways, or their walk to and from home is filled with advertisements of 2-meter tall candy bars and the newest fast food item or the newest treat, those healthy food choices do become almost impossible. So now I get to bring up some elephants in the room. Regulating or restricting any part of the food environment does get you quickly sometimes labeled as the food police. Whether or not the evidence does support it, there is a huge emotional aspect to this within communities and within just individuals whenever it comes to food choice. And there are very practical constraints that do prevent certain councils from going all in on specific food mitigation measures such as TMZs. So in addition to policy implementation in future LDPs, if we refuse a takeaway, it's very likely that we will need a public health officer who is informed and trained enough to write a robust enough response that can stand up to legal challenge during the appeals process. And also, as stated before, NHS boards are going to act as that public health official and as that key agencies, but especially to folks that are in the UK right now, it is not news to anyone that the NHS is currently incredibly stretched, and sometimes expecting a 21-day turnaround on planning consultations can be a massive ask, especially if they are all coming in from multiple councils all at once. And additionally, we still do have the classic planning versus licensing design. What is actually in our remit that we can control? Planning controls the use of the land, licensing controls what's on the menu, and heck, neither authority has jurisdiction on whether or not kids will just, again, anecdotally order food delivery services like Deliveroo from outside a walkable catchment directly onto their school campus. So we will need a more joined up approach, like Michael Chang was saying, if we are going to tackle social and commercial determinants of health effectively. And lastly, on this page, from a more systemic perspective, changing behaviors and attempting to work together to improve health is fundamentally a very complex problem. And complex problems become, thankfully, clearer with honest inquiry and good data. But with good data, the answers are often harsher, less equal, and less comforting than people want them to be. This will likely be the case when considering that objectives relating to economic growth may not always align with the objectives set for improving public health. They will sometimes clash, and we will have to have very difficult, very good faith discussions with a lot of people to find sometimes what will be called the not worst option of the bunch to keep that going. So to wrap things up, I do want to leave you with a couple of actionable things that you can be doing wherever you may be. So underlying tactics, regardless of whether you're in Scotland or in Hong Kong or in England or anywhere that you might be watching this from, entirely replicable. You can begin demanding rigorous health impact assessments from developments in your pipeline, or you can advocate to have smaller health statements on even smaller or mid-range projects. I would also heavily encourage that you voluntarily integrate public health officials into your consultations and in early drafting processes. I would even go even further and say if there is any health and planning action boards in your area, join those. You'll be able to break down so many more silos and have so many more discussions from seeing what kind of projects they have in place already. You can also access things like the Place Standard tool, which is freely available online, by the way. And you can adapt its various lenses and methodologies for your community engagement workshops. So the mechanisms are already in your toolkit, and it also really does require a bit of a cultural, a bit of a mind shift in the perspective of what the planner in general is meant to achieve. So long as we keep treating the streetscape itself as a prescription for public health, we can heal the community. So again, I want to thank you for listening through my whirlwind, very high level overview of what we're working on here in Scotland. I know it's a lot, and I'm so happy to see the progress that we've made even at this stage, and I'm happy to take any questions.
Thank you very much, Marisa. That was really helpful and give us a good insight, I think, on the current position in Scotland. Now I'll hand over to Rebecca.
Okay, I'm very, very inspired. And I think so are the attendees joining this section. So if people have not noticed, you can actually put in your questions on the chat box and we'll answer your questions. But I will take the liberty to ask the first question to Dr. Fan first. And with us today, we have two guys behind the scenes doing healthy cities. With Dr. Fan, one is Lawrence and one is TW. So I'm going to ask you three to answer the question. You're not supposed to ask questions. Okay. So in the high density cities in Hong Kong, what are the practical urban planning and design strategies we consider effective in improving both physical and mental well-being at a neighborhood scale. We just heard about the health impact assessment. Coming from like a developer, I'm very mindful of another assessment, but there is actually value in doing that. So I'm going to ask Dr. Fan to answer this question first, and then Lawrence and TW to think about possible answers.
I'm very envy about what is going on in Scotland or UK is you have really put it into regulation or policy that to try to integrate the public health into the city planning. I hope this is happening in Hong Kong, honestly, because I think the audience here in Hong Kong understand that indeed the housing bureau has tried to do the well-being project, is trying to put in the public health element into the public housing in the future. And because I was involved in that. But even after release of the report, it seems not much related to the public health. I would use the substance has been imposed. I truly appreciate what Marisa has mentioned is there is a conflict between the commercial determinant, because government is also looking at the commercial determinants because they are the key stakeholder. I mean the business world and also how to run the GDP, I would say, is affecting the government mindset. But of course, as a public health or as a doctor, we also think that the GDP is also affected by the people health status. When you are getting more healthy, you can be more productive. When you are retired, you are still having less chronic illness, then the city need to pay less on the health burden. But how to do this cultural mindset shift? I think it's a long-term commitment from different stakeholders. As mentioned, in UK, it's not only the NHS. In Hong Kong, it's not only the doctor. We need to engage as many people as possible. And this is what I try to do in the community to set the example is, even for the underprivileged, they look for help. And there is a solution out. And this is, I try to say is this may be the way forward in Hong Kong because we don't have space. But how to create possible, accessible, healthy element among the limited space to use the voice and also the force from the community may be another way around is a bottom up.
Lawrence, any supplement?
I think I just continue. Actually, our thinking is to do a spatial and community planning, not just spatial planning, but spatial planning is really an elephant in the room for Hong Kong because in the old urban areas, Mong Kok, Yau Ma Tei, if you know Hong Kong, you must be you will also be aware of these old districts, which are really with very level pavements and very overcrowded, very populated, and the pavements will be only up to one meters, yeah, as level as that. And by the way, actually, Hong Kong is famous for public transport. Over 90% of our people are using public transport and just walking to the public transport stations. And so it's really very unsafe and undesirable, particularly for elderly when we are an aging community. The median age is now 47 years old. And so it's simple. If we can improve the pavements and we can allow people to walk, and then we can create more public space in the community. The NGOs and the community groups can use these public spaces. Yeah. By the way, we have possible solution space because the Mong Kok MRT is an old layout with 40% more space, but problem is basically used for vehicle, even for on-street parking. but we are so in a way so ungenerous not to provide for pedestrians, not to provide for pavement. So our project with big support from Dr. Fanning and Professor Albert Lee, our emeritus professor of Public Health Department of CUHK, and we are trying to push forward this spatial and community-based planning solution. Thank you.
Thank you, Lawrence.
Thank
I'm
you.
going to ask you to answer a question later. We now pass to Philip. There's a lot of questions in the chat box. So,
Yeah. We've already got a few questions now. Just briefly wanted to go back to Marissa in terms of hot food takeaways. Initially, I had a few thoughts as well and wanted to ask you a question, Marissa, if that's all right. And we
Absolutely
also have a question from Margareta Davis as well in that regard. I was wondering, with regards to the health-based zoning, how this would apply to existing hot food takeaways within these takeaway management zones. So are these businesses able to operate as before, or are they able to expand in the future, and how would that work for existing ones? And then we had also a comment, sort of question from Margareta Davis in terms of takeaways. Basically, if you would refuse takeaways going forward through the local plan, and instead put gymnasiums everywhere, she believes that it doesn't make much of a difference because people aren't well educated and or have not, or don't make an informed decision. So could you please also respond to that a bit?
Yeah, I'm happy to respond to that. I will say that these questions are being echoed throughout. While takeaway management zones have been very defensible down south in England, and we have used those as case studies, of course, the Scottish environment is something very different, and we are operating through constraints. For example, like you were saying, licensing is what controls the existing places, and we don't necessarily have an evidence base currently at the moment that can support saying, this is the quota of takeaways that we can have in an area. There's also the discussion of whether or not this is the best option for mitigating obesogenic factors in our area. So across councils, there's different opinions, there's different appetites for things, and even across communities, there's different issues relating to that. But one thing that I really try to at least implement or try to encourage is not thinking of takeaway management zones as a silver bullet. It's not going to fix everything. It's not going to change health education. It's not going to change anything else in the huge factor, but it will have a fix. It will have something tangible, and it is something that we can do. And like Michael was saying before, things are not going to happen by accident. They actually do have to have a tangible policy impact. And so if that is involved with implementing some sort of takeaway management zone on future developments, it might cause a bit of pain in the future, but we will have a policy to move forward with that. Other things that we're working to consider when it comes to constraints for implementing takeaway management zones, they're very related to economic factors as well. A lot of our schools, especially in rural settlements, are very close to the town center. So what do we do if a 400-meter catchment is most of the town center? You can't necessarily have any kind of public or community support of saying that there is no food on your high street to access quickly. So there is also that factor, which is why some places are working on making very comprehensive health impact assessments, fun acronyms, in addition or sometimes in absence of a takeaway management zone in their future plans. So lots of discussion is still going to be had. Thankfully, most of our communities and most of our councils are still in the evidence gathering stage and not in the prepared plan stage. So we'll be able to smooth those out and hopefully have a more tangible and happy answer for you in the years to come.
Thank you, Marissa.
Thank you. I will follow up on the takeaway later. But first of all, I would like to ask Michael a question in the chat box. From Laura, she is interested to know whether there are good systems that exist to help integrate HIAs into the planning process. She's a service designer and spent many years working with both planning systems and NHS to improve the service pathways and the digital systems. So she's interested to know whether there's a role for better data and technology that enable doing so to support the development and adoption of the HIAs. So literally, how do we actually implement the HIA's implications into the planning system?
Thank you. I also have a few issues on the takeaways I can follow up on with you as well, Rebecca and Marissa, because I was leading on the planning for health food policy in England up until early last year. On the HI issue, I think, Laura, I wasn't quite sure whether you mean planning in the wider NHS planning sense or planning as in town planning, urban planning, because we do use the same word, planning, for various different things. So I assume because the webinar we are about town planning today, I'll answer your question in terms of the urban planning, town planning perspective. I mean, there are systems in place, and actually, you know, there are procedures that you can better integrate HIAs into the planning system as we engage with the NHS and the public health teams. So, for example, we can do it as a standalone HIA, or we can do it as part of an environmental impact assessment or any other impact assessments that have been done in the planning system. And there are tools already out there that the private sector has developed that help standardize information on platforms that are widely available with a fee, of course, that you can try and integrate GIS and other data sets to better understand those issues. And then finally, I would say is a lot of the issues isn't really about the system or the process, but the people. What we have found, at least with the health impact assessments, is that we don't quite have the right people in place to understand HIAs, even though they've been around for a long time. We don't have the right people in place to help review the HIAs. We may have the right people in place to do the HIAs, but they are guided by policy requirements. And also, you know, if you don't develop the right policy guidance, the quality of the HIAs and what you get out of the HIAs will be very variable based on their policy. So I don't know whether they can answer your question. Very happy to pick it up separately on that. But there are already existing things that we can do. Just going to say I'm currently publishing a guidance on HIAs in the planning system, which may be helpful when it's out in the summer. And I'll also be working with the Royal Town Planning Institute to produce a planning advice note on HIAs in the planning system this year as well. Thank you.
Thank you, Michael.
Thank you very much, Michael.
Yes.
I think in terms of HIAs, as you just mentioned, they're around since a few years now, and I think one of the main issues is that local authorities, some of them have adopted planning policies in England, but as you showed during your presentation, I think there's still a lot of work to do in terms of adopting new plans and integrating planning policies in their upcoming local plans. So I wonder, Michael, from your perspective, what can be done and what can, for example, the NHS do and other stakeholders basically to encourage local authorities to implement and adopt local plans, integrating specific planning health policies, because these planning health policies will then enable, you know, and have a leverage for demanding and asking developers and promoters for health impact assessments on a, you know, more standardized basis, so to speak.
Yeah, I think the key issue here, I think, Rebecca, you're saying that you were from a developer perspective, and so we're very mindful of potential actual and perceived burdens on the industry to pay for any assessment or additional assessments. That was one of the pushbacks that we got when we were trying to make HIAs, at least in England, more of a formalized national policy. But the pushback was it's maybe a regulatory burden. I think the key thing, I think Marissa can mention this in her presentation, the key thing about an HIA are two things. Firstly, they should be done where they matter the most, not mainstream tool. It should be a mainstream tool, but on developments that may have the potential for positive or negative health impacts. So as I mentioned in my presentation, deprivation is always a key indicator. If you are developing in a more deprived area, an HIA can be useful to draw out those nuances in the population health that you can't pick up on from the other assessments. The other kind of thing I want to add is that an HIA assessment is only as good as the policy that was drafted to help with the HIA. Most HIA policies that we come across basically say, we do development, do an HIA, and that's a tick in the box. Actually, not many policies do this. The policy should be worded that the development should be demonstrating they have been informed by the HIA, not that they've just done an HIA. So therefore, the burden, yes, is still on the developer to demonstrate they've done this, but the HIA reporting mechanism is actually less important. But what's most important is developers, through their planning process, has demonstrated that the HIA has informed and improved their scheme, and the HIA reporting is just a way to validate what they've said. So that's how we're approaching that in England. To say, yes, the burden should be on the developers to demonstrate how they're contributing to population health, using HIA as a lever, and then to do HIAs where they matter the most and to demonstrate where they've made an impact. Finally, Philip, you mentioned our health policy. My research have found that only about a third of the local plans have an HIA policy, but most local plans will have a particular health objective. So we are already seeing planners and the planning system recognizing health in their local policies. The key question is then how do you deliver that? And HIA can be one solution, but not the whole solution.
Thank you very much, Michael. Just before I hand over to Rebecca again, just want to remind attendees to ask their questions and put them in the Q&A box on the right-hand side, please. Thank you.
Okay. We have a question from our Indonesian friends. The question is, it's been observed that in Indonesia, there are already many community-based health programs and health supporting infrastructure initiatives. However, the public participation always remains very low, especially during the planning and decision-making process. And people tend to become more involved during the implementation or when the benefits are directly visible. So in your opinion, what are the main factors behind this condition? I guess it's the same for Hong Kong and also, I guess, UK as well. So what are the main factors behind this condition, and what strategies could help to encourage more active and sustainable community participation in developing the health supportive infrastructure? I think that I will ask Dr. Fan to answer this question first, then followed by Marissa and Michael.
I think it's related to health literacy and also about the understanding of what is social determinants of health. I think this concept is very important to a lot of the, you can say, the population, whether they understand how to manage the health. Because honestly, in Hong Kong, still quite a number of people is, when you get a disease, you go to see a doctor. Concerning about health is about doctor. Of course, concerning about health is not about the doctor. It's about how you can have the access to healthy lifestyle, no matter it's construct already built in around the environment, or you can have the access to those healthy lifestyle, you can say public or private facilities or even food source, things like that. So this is about the general public policy. It's not about only the health policy, because health policy cannot override some of the public policy. So that's why I think
Suggest?
a whole population understanding of this aging society, when you, I set a very clear milestone. When you get retired, you can go to still go on to have enjoy the life. When you are retired, you've got a lot of disease. This is a failure of index. And how we can make this into a language that the general public can understand. I think this is the way how we try to move the language, use the language to move the people to be engaged, to let them know that their involvement about the city design or how to make their living space to have more health element is very important for them to live up to the retirement, after retirement, how the way to enjoy life.
Health literacy.
Yeah.
It's like financial literacy. We all need to have the literacy. So I learned a new term today. So Marissa, from your angle.
Thank you. So just like you were saying, and to add on to that, engagement is a very tricky beast. To even get people to come or to even care about what you're talking about is something that people can make their entire careers and base their entire careers off of, and they do continue to do that. One thing that I have found, at least in my experience when it comes to engaging communities, is the most successful ones have a level of agility paired with their engagement in their consultation. I thoroughly believe that every single consultation and every single engagement with the community should have a very tangible, visible takeaway. Even in long-term complicated problems like public health or like just anything underneath that umbrella should have something that people can walk away from and say, oh, this is something that I can do, or oh, this is something that is immediately fixed. So being able to capture small bets that people can take. So for example, we can't fix narrow pavements overnight. That is not something that we would be able to do. But I am going to use a specific anecdote of something that we've done in a recent consultation in rural Scotland. We were consulting on the built food environment. Something came up saying that there was an area that was very good for local communities. It was actually surprisingly a huge center that people just did not actually understand was a good place for people to gather. And since then, they have actually started hosting events on food literacy, on cooking, doing little raffles or bingos that are related to just having people understand and having them gather for that. And in addition, there was things talking about, again, for public health, having areas for breastfeeding around the area in that small town. They noticed that there was a huge deficit of people willing to advocate for communities and businesses to actually have those places in public areas, and also a lack of people willing to actually implement that and go and advocate for that. So they have actually made a little bit of a task force around that and have been able to increase just since March the amount of breastfeeding spaces within their public area by at least 10-20 businesses already. And they're already having that energy from that. If we were to just go and consult, write it all down, put it in issues and actions paper in very, thorough, legally defensible actions, I don't believe that the next consultation that we'll ask of them would have a very similar response to people coming out. Again, last thing, we have to use clear language. If there's a literacy problem with food with the food system and just understanding what's healthy and what's not, the second that I would bring up a single acronym, if I were to bring up, for example, NPF4 or say the word obesogenic factor, I've lost them. So clear language, going to where people already are, and having a tangible, visible takeaway are probably my big three key factors of engagement.
Thank you, Marissa. Michael?
Thank you. Very briefly, I do recognize the issue with engagement, and that's just not with the public also, but with the wider non-planning sectors engaging with the planning system, because as Marissa was saying, language is so important. Necessarily, planning has to have that language because we are a quasi-legal, we are a legal system, and therefore it can be taken to court by doing something wrong in the planning system. And therefore, the complexity of the system is necessary, but it's also a barrier for those who are not trained as town planners. So we kind of had to address that particular issue around communication. The other one is looking at trust. I previously worked in an organization that looked at trust in the planning system. And because of the fact that it's so complex, the planning system, you get involved in it at some stages, you don't see the outcome, then you lose trust in the system, you lose trust in the leaders that make a decision. And sometimes what I have found in my current work and previous work is that engaging researchers, universities, as well as consultants can help bridge that gap, because people tend to trust those researchers a lot more than professionals. So engaging them in the planning process can be quite useful to get their views across, and hopefully that will be reflected in the policy at the end of the whole process. Finally, I would say in terms of the constraints, and we all are public, you and I can always get involved in the planning system, even though we're not, involved in it professionally. So we understand intuitively, personally, what it takes to be involved in the planning system. And we're expecting people to take time out of their day or evening to be involved in consultations and things like that. So be very mindful of those issues. I would say, in terms of drawing my contribution to a close, is that mechanisms like an HIA and those things can be quite useful, because those are legal structured processes and getting involved in the process and getting your views heard in the planning system. And therefore, again, it's something that I kind of communicate quite a lot to professionals, is understand where you can have most leverage in the system and get involved in it. Policy is very abstract, 10, 15, 20 years down the line. And that's why most people don't get involved in plan making consultations, but on regeneration projects. We just have to understand and make them understand that what's happening now has been a result of decisions made 15, 20 years ago. So we kind of have to make sure the planning system is accessible, but at the same time, making sure it's robust enough to respond to future challenges.
Thank you. Well, we have a few more minutes. I'm going to ask a question. I understand Raymond has asked a question, but I'd like Hua Guo to answer a question. Yeah, because since you have been involved in this Healthy City initiative, how can planners be more effectively collaborate with the public health professionals and medical experts to translate the health-related data into spatial planning strategies? So Hua Guo has been working in this Healthy City for a while. Do you want to come up and answer the question? I definitely put you on the spot. Yeah.
I think there are a number of things I've learned. I just like to share my own experience, as maybe different people have slightly different ways. But for myself, I mean, I think it's one thing that's very important is to have the language. That means, well, not the language of planners, the language of other people. So the first thing is you listen and try to see and find out what they are concerned about. And we, just like Dr. Fan mentioned, is the health literacy. So what local people are concerned about, the health things. So these are the important parts. And also in terms of delivery, and also the local context, different community, different age group. I mean, we have a very interesting mix of elderly. They are active elder, and there are certain more senior ones, they have a mobility problem. So through the engagement, we know the issue, the problem they're facing. Also through the process, we allow ourselves to work with different organizations, just like Dr. Fan, and also some local NGOs. So these are important local connections. I think planner is an interesting profession. We tend to know quite a bit of things, but always the old Chinese sayings that you should learn anything every day. So there are a lot of things that you can learn and find out, and also even you know about these things, then you can try to verify, is it exactly the situation in that district? So the district may be facing some different issues, like we talk about like obesity. Are we having that in our district? How different areas are they slightly different? So I think that is something, well, I think it's important. And also, well, important is to update ourselves, to learn different skills. Like in this evening's presentation, we talk about the spatial data, spatial analysis, a lot of these community things. I think there are a lot of things we need to learn, integrate into the planning before we can shape and work with others. So that is something throughout the past few years, I think is something I've learned. I think it's essential and also maybe a starting point. If I work in another district, I will also try to keep up myself because, well, there are a lot of things are changing. So we need to make sure we are somehow up to date and knowledge of certain things and the characteristics, the uniqueness of that district through the community engagement we get to know. So that's roughly I can recall some of the points. Thank you.
Thank you. Thank you.
Thank you very much.
Okay. The last question Raymond asked. Raymond is here with us. To all speakers, and this is the last question. I'm mindful of time. To all speakers, can you share some examples that you're aware that about smart city elements which have been used in the Healthy City initiative? So I will start with Dr. Frank first. Very quick answer, and then to Marissa and Michael.
I'm still using the same strategies to really engage the local key stakeholder, and not only about the public, but also from the commercial side on how to make it the population healthy together. Because even the owner of the shops, they are still facing the same health issue. So they are also part of the beneficiary. So to get them involved I think is the most smart way to push the thing forward.
Smart city elements is to involve the people who can actually who are stakeholders as well. Okay, Marissa.
So I will go off of a few case studies that I've been researching very recently about how, for example, machine learning and Internet of Things sensors can actually gather a lot of the data before you can even go to promoting that to the general public. So for instance, this actually might be able to be answered by folks at Hong Kong a bit better. I am aware that there is a framework called Deep Air that is able to actually accurately forecast fine-grained hourly pollution levels, which do help with political and public health interventions surrounding monitoring and improving the air quality. The second one is in Hamburg, which is in Germany, which was able to implement real-time monitoring in a system of high traffic areas, which helped swiftly identify overcrowded spaces, issue alerts, and issue compliance. And then there was also San Francisco. They had a data collection method called CycleTrack smartphone app. It tracks the real world cycling routes and travel times, which help cities prioritize safety investments and also expand things like bike lanes and encourage those healthy and active transportation methods to the general public. I have a couple more, but yeah, that's just from the notes that I was able to take.
Thank you. Michael?
Very quickly, so the NHS England Healthy New Towns program here in England between 2016 and 19 did invest and pilot a few smart city related elements. One really quick example, and this is about behavioral change rather than physical interventions. This is in Ebbsfleet Garden City in the southeast of England. They funded and supported residents having smart apps, and things like that to track their usage and the activity across the environment. And they can gain points and rewards at the same time. So rewarding them for being physically active, for example. And they did find very positive outcomes from evaluation. So there are good examples of that. I think the key thing is here about changing behaviors and improving behaviors than just investing in hard infrastructure, because we know that, as one of the participants was mentioning in the Q&A earlier, it's very hard to change and affect individual choice. Therefore, a lot of public health initiatives are about behavioral change than just interventions.
Thank you. Thank you. So we have come to the end of today's webinar. I've learned so much, and I'm sure let's make this like a regular series of Healthy City webinars. A quick promotion. we will have another joint webinar on the 6th of June with the Malaysian Institute Planners. And this time on Urban Renewal, a very dear project to our planners' heart. We have the Managing Director of URA, Donald Choi, and CEO of Malaysia's Kompang Baru Development Corporation to be our guest speakers. So we look forward to seeing you guys, LTPI members, all our sisters institutes are welcome to join, and it's free of charge. Okay, so thank you again to all our speakers, partner institutes, and everyone who joined us today. And Philip will conclude.
Thank you very much, Rebecca. I just have just a few closing remarks. Please complete the RTPI survey that will appear once this webinar has finished. Please also get involved on X at RTPI_Yorks. After this session, we will also provide you with a link to the recorded webinar. And then also, as Rebecca has just mentioned, further webinars are coming up from HKIP, but also from the RTPI. And also, please visit our website for 2026 and more upcoming webinars on rtpi.org.uk/events. Thank you very much for attending today, this afternoon, this morning. We're very happy with the questions and with our conversations. And thank you very much to our speakers again for their contributions and talks.
Yeah.
Thank you very much.
Thank you so much. Bye-bye.
Thank you.
Okay.
Yeah, thank you so much.